So good evening, everyone. So I will be talking about the treatment of both HER2 positive, early, locally advanced, and metastatic breast cancer, which are HER2 receptor positive, HER2 positive. So as we know that breast cancer, that is the most frequently diagnosed cancer, and it is a cause of cancer-related death among females worldwide. And in the United States, around 5% of the women they are diagnosed with breast cancer uh, in their lifetime, and these patients they are more 5% are metastatic at the time of their presentation. And despite the gain in the early detection, even 5 to 10% of patients are diagnosed which are in the stage 4 disease, and 30% of the women who are in the early stage non-metastatic breast cancer, they will ultimately develop metastatic disease. So, and in all the cases, in all the patients of breast cancer, around 20% of the patients, they are positive for HER2 receptor, HER2 positive. And now I'm giving a brief review regarding the HER2 directed therapies which are available, and when to use them, how to combine them, and what are the indications of all of these therapies. And we as know that high level of the HER2 expression or the overexpression, that is determined by either a 3+ staining on the IHC, in which we detect the HER2 protein, or the evidence of the HER2 gene amplification by FISH, in which a FISH ratio of more than or equal to 2, we consider that as a positive and likely that patient that is a strong predictive value in the treatment of a HER2 positive cancer. And all of the patients patients who don't express HER2, they will not benefit from any of these. And in case of a metastatic disease, biopsy of the metastatic site that is recommended as uh, the marker status, hormone receptor positive or negative or HER2 positive, that can change when even the disease become metastatized. Now, the various drugs which are available for targeting the HER2 are the trastuzumab, pertuzumab, TDM1, and tucatinib, neratinib. So now I'm going to start with the neoadjuvant chemotherapy. It's a phase in the neoadjuvant setting. I'm going to start with it. It's a phase 3 train 2 trial in which neoadjuvant chemotherapy with or without anthracycline that was done with dual HER2 receptor blockage in metastatic so it's in a neoadjuvant setting in the early breast cancer. So it was a phase 3 trial which was open label randomized, and the patients with HER2 positive early breast cancer, stage 2 and 3, and no previous therapy, with performance status of 1, 0, or 1, and with left ventricular ejection fraction more than 50%, they were randomized to 3 cycles of TCHP, followed by 6 cycles, followed by surgery. And in the another arm, they've given 3 cycles of 5-FU apiribicin based treatment and the trastuzumab with pertuzumab, followed by 6 cycles of TCHP. And then after surgery was done, and they completed adjuvant trastuzumab for a total of 1 year. And in this, the primary endpoint, that was the PCR, that is by local assessment, and the secondary endpoint was the overall survival and the relapse-free survival. Next slide, please. So in this trial, the primary endpoint of PCR, like we have seen that higher rates of PCR, they are seen even with or without anthracyclines, and they were almost similar. Like as we can see that out of 206 patients who were in the arm in which they have used TCHP, the PCR rate was around 68%, and in the another arm it was around 67%. So the main outcome that was consistent across all the levels of the pre-specified subgroups, and that is there is no difference, and there was no difference in the event-free survival or the overall survival. Next slide. And in a safety profile at the 3 year of a follow-up, we have seen that in the arm where we have used TCHP, where the neutropenia that was at 54%, and in the another arm it was 60%. So this is a comparison of the different side effects profile in both the arms. And anemia, it was almost similar in both the arms. Thrombocytopenia almost similar. But the incidence of febrile neutropenia, that was more in the arm where we have used epidubicin 5-fluorouracil. And the non-hematological side effects, they were like diarrhea, hypokalemia, diarrhea, and that was more in the TCHP because of in the TCHP, and the hypokalemia, that was more in the 5-FU group. Neuropathy almost similar, fatigue almost similar, but these are the main side effect profile. But as we can see that the left ventricular ejection fraction in the TCHP, there was a decrease of more than or equal to 10% in 22% of the patients, and it was more in the another arm of in which 5-FU was used. It was 36%. Next slide. So this is affinity trial. It was a phase 3 trial, placebo-controlled trial, in which pertuzumab along with trastuzumab and chemotherapy versus single, the no pertuzumab. It is trastuzumab and chemotherapy in HER2 positive early breast cancer. So it was an international randomized double-blinded placebo-controlled phase 3 trial. In surgery, the patients with HER2 positive breast cancer, they were randomized to receive chemotherapy along with pertuzumab and trastuzumab in one arm, and chemotherapy with trastuzumab and placebo in another arm. Treatment was completed for a total of 1 year, and in a 10-year follow, the primary endpoint was IDFS. Secondary endpoint was IDFS, OS, distance-free recurrence survival, DFS, cardiac safety, health-related quality of life. So these were the secondary endpoints. Next slide. So as we can see that in the 6-year follow-up, the safety and we can see that there was no difference in the fatal adverse event in both arms, pertuzumab as well as in the another arm. But we can see that more primary events in cardiac events, they were more with the addition of the pertuzumab, that was 0.8% versus 0.3% with the placebo. And as we can see that with the addition of the pertuzumab, the overall survival rate that increases. Next slide. So Catherine trial, in which TDM1 was used versus trastuzumab in adjuvant therapy in HER2 positive breast cancer. Patients were given neoadjuvant treatment, trastuzumab surgery we see for the PCR, and in case they do not change the PCR, we divide them into either the TDM1 in a dose of 3.6 milligram per kilogram 3 weekly for a total of 14 cycles, or trastuzumab 6 milligram per kilogram 3 weekly for 14 cycles. And next slide. So in this, we can see that in the primary IDFS, in the TDM1, it was 12.2, and the distant recurrence, that was more in the trastuzumab, it was less with the TDM1. Loco-regional recurrence, that is also less with the TDM1, and control-little cancer, that was also less with the TDM1. So CAN trial, that becomes a landmark of using this TDM1 in this setting. Next slide. Next slide. So all your development happening in more than 15% of patients in either the arm. So we can see that in the TDM1, there was more fatigue, more nausea, thrombocytopenia is more in this arm, and increase in the liver enzymes, transaminitis, that is more, and skin in this year, epistaxis, that is more, increased risk of bleeding with the TDM1 also in some patients. more constipation, more neuropathy. So these are the in the TDM compared to the trastuzumab group. Next slide. Yeah. So Extenet, there is a 5-year update. So it's a neratinib versus placebo after using adjuvant trastuzumab in HER2 positive breast cancer for 1 year. So in this stage 1 to stage 3 patients, they were enrolled after trastuzumab. Uh, less than 2 years, they were randomized to receive the neratinib versus placebo. And the primary endpoint was IDFS at 2 year, and the primary analysis at 2 year IDFS rate neratinib was 93.9% with placebo of 91.6%. Next slide. So this is extra. It's a 5-year IDFS analysis. As we can see, there was almost similar. Next. 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 Yeah. And the next slide. Yeah. So this is a fixed dose subcutaneous combination of pertuzumab, trastuzumab in HER2 positive early breast cancer that has covered by the ma'am also previously. So next slide. So HER2 positive, HER2 targeted therapy and early breast cancer. So the adverse events are that with trastuzumab, pertuzumab. So it's cardiac toxicity, which is rare. Common is a diarrhea, which is quite common. That is seen in around 30 to 40% of the patients on this combination with pertuzumab mainly. And infusion reactions rare. Neratinib, mostly GI side effects like diarrhea, rash, and liver toxicity, cardiac toxicity that is rare with this. And uh, there are some drug interactions with the neratinib, and the TDM1 that causes more of a thrombocytopenia, transaminitis, neuropathy, cardiac toxicity, and the liver toxicity, and then infusion reactions which are rare with this drug. So next slide. So this is a diarrhea outcomes. As we know that a neratinib that causes primarily GI side effects. So we can, as per the, we can need to start with the lower dose, say 120 per day for day 7. If patient tolerate, then 160 milligram. Then gradually we need to increase the dose. And the incidence of diarrhea with neratinib is around 40%. But if you use the prophylaxis for diarrhea, then the incidence that drops to around 5 to 6%. So we can use loperamide along with this also as a prophylaxis for diarrhea. Next slide. So consideration for management of a neratinib-induced diarrhea. So neratinib strategies at time of initial therapy. So we need to start neratinib at a lower dose and gradually titrate it up, and to use loperamide at the first dose of a neratinib. Dose modification, it's based upon the grading of the diarrhea. If the diarrhea persists, then in the grade 4, if the grade 4 diarrhea, then even we need to discontinue the therapy. Next slide. So this is WSG ADAPT TP. It was just presented in the ESMO in 2021. It's a basically de-escalated neoadjuvant TDM1 with plus minus endocrine therapy versus trastuzumab plus endocrine therapy in hormone receptor positive and HER2 receptor positive early breast cancer. So it was a phase 2 trial, small number of patients, 375 patients were enrolled. Primary endpoint was PCR, and with TDM1, the PCR was it was 41%, and with TDM1 endocrine therapy, it was 41%. With trastuzumab with ET, it was 15. And there was no difference in the overall survival in this group. Next slide. So Compass HER2, it's a new adjuvant TH. We have given THP and adjuvant HP in patients receiving PCR. So it was a phase 2 trial again. And THP, 4 cycles. Taxane used was either paclitaxel or docetaxel or nab-paclitaxel, and then along with the dual HER2 blockage, we assessed for the PCR, and the primary endpoint was relapse-free survival for 3 years. Secondary was IDFS, DDFS, and the overall survival and EFS. Next slide. Next slide. So these are the ongoing trials. in HER2 positive early breast cancer, like I am patient fifth year using atezolizumab, and then there are trials with TCHP versus TCHP plus atezolizumab. So these are the ongoing trials. These are all other phase 3 trials. So Destiny, Destiny 11, Estefania. Next slide. In HER2 positive metastatic breast cancer treatment approach. Next. So yes, Cleopatra. So as we know that Taxane along with HER2 blockage, dual HER2 blockage in HER2 positive metastatic breast cancer, we can see in this curve, in this Kaplan-Meier curve, that the median overall survival that were with the dual blockage, it was 57, and without it's 40. So, and the PFS in this intention to treat population with the triple drug it's 18.7, and with dual blockage it's 12.4. So it's a significant. Next. Amelia and Theresa. So it's TDM1 as a second line therapy for HER2 receptor positive metastatic breast cancer after progression on HER2 targeted agents. So Amelia, so it was a randomized trial. It was a phase 3 trial in which TDM1 that was in the one arm, and in the another arm there was lapatinib and the capecitabine for HER2 positive metastatic breast cancer with progression on the trastuzumab. So we are giving it on the second line, and median overall survival with TDM1 that was 30, and with the lab cap it was 25.1. And then TH3 research trial, it was a phase 3 study of TDM1 versus chemotherapy of physician choice. TDM1, with TDM1, the overall survival is 22 months, and with another drug of the physician choice, it was 15.8 months. So next slide. Yeah, Destiny, it was a trastuzumab deruxtecan versus TDM1 as a second line therapy. So it was an open label phase 3 study in which patients with unresectable metastatic HER2 positive breast cancer who were previously treated with trastuzumab in the advanced or metastatic setting, they progresses, they were randomized to receive either trastuzumab deruxtecan or trastuzumab emtansine. A median follow-up, we can see that the primary endpoint was PFS, and secondary was overall survival, and the interim PFS it was available in the mid 2021, and so it's a median just follow-up of in the both the drugs is 16.2 and the TDM1 is 15.3 months. So next slide. Next slide. So in the Destiny, when the in this subgroup analysis, we can see that all there were this is as per the hormone receptor status and prior treatment with pertuzumab, any visceral disease, and with the prior lines of the treatment, and the patients with the involvement in the brain. So these were the patients who were taken, and the median PFS with the hazard ratio at this point towards in the favor of the trastuzumab deruxtecan. Next slide. So PFS by investigator assessment, as we can see that with deruxtecan, the median PFS was 25, and with TDM1 it was 7. And OS, it's early data. It's a median OS. It's still not mature, but the 12-month overall survival that was 94 and 86 in the TDM. Next slide. So it was a safety and adverse event. Like we can see that any drug-related adverse effect more than or grade 3, they were more in the trastuzumab deruxtecan arm compared to the TDM1. And drug-related side effect which led to discontinuation of the treatment, that was more in the trastuzumab deruxtecan, and no deaths in both the arms. And the most common adverse event associated with this trastuzumab deruxtecan is an interstitial pneumonitis, interstitial lung disease. With TDM1, it's thrombocytopenia. And the most common adverse event associated with dose reduction in the deruxtecan, it's nausea, neutropenia, and in the TDM1, it's transaminitis and thrombocytopenia. No grade 4 or 5 events of drug-related interstitial pneumonitis or decrease in the LVF in this group. Next slide. So in HER2 climb, these three drugs are combined: tucatinib, trastuzumab, and capecitabine in previously treated patients HER2 positive metastatic breast cancer. And it was a phase 2 trial. Patients with brain mets, they were allowed in this, and tripled the combination: tucatinib 300 milligram twice a day, trastuzumab and capecitabine 1000 milligram per meter square BD dosing. That was compared with the trastuzumab and capecitabine and placebo. And the primary endpoint was PFS in the 480 patients which were taken in this study. And the secondary endpoint was a OS and PFS in patients with brain mets. Next slide. So we can see that the median PFS with tucatinib with the triple drug combination, that was 7.8 months, and with 1 year PFS, that was 33, and with the placebo it was just 12. So it's a significant. So there's a decreased risk of progression, in particularly in the patients as the patients with brain mets, they were also included in this study. So next slide. In patient with brain metastasis, we have taken that with the triple drug combination, the median overall survival is around 22 months, and in this another arm, that is 17, with the 2-year overall survival of 45% and the 27% in dual drug combination. Next. So overall survival in all patients with brain metastasis, so as we know that triple drug, that is a better median overall survival, and improved overall survival with longer follow-up. And 12 months previous analysis was at 18.1 versus 12 months. Next slide. So overall survival in patients with active brain metastasis. So as we can see that the was overall survival in patients with active brain metastasis versus with a stable order treated brain metastasis. So the difference is more, and triple drug combination that favors that performs better compared to the dual drug combination. Next. So this is HER2 climb CNS PFS in patient with brain metastasis. So the patients with brain metastasis, as we know, it was tucatinib, trastuzumab, capecitabine, significant p-value, median PFS 9.9, and with active brain metastasis, tucatinib, and it was 9.6, almost similar. With stable brain mets, it was 13.9. CNS PFS benefit in patient that was maintained in the tucatinib arm with a longer follow-up even. Next. So intracranial overall response and duration of response in patients with active brain mets. Patients with complete response or partial response, there were 26 with tucatinib arm, and in the another arm, there were just 4 patients. And patients with next slide. So the most common adverse event, there was diarrhea, PP syndrome, nausea, fatigue, stomatitis, loss of appetite. Next. Is the NALA. So it's a neratinib versus capecitabine, and neratinib with capecitabine versus lab cap in HER2 positive MBC with more than prior 2 lines of a therapy with HER2 targeted agents. So it was a phase 3 trial. It was an open label trial, and the patients with confirmed HER2 positive metastatic breast cancer previously treated with more than 2 lines of a HER2 targeted therapy and with a stable brain metastasis, they were enrolled. And neratinib and capecitabine versus lab cap. As we know, the dosages, they were given a 21-day cycle, and then until PD or progression. The primary endpoint was PFS, and the study was positive. There's either endpoint statistically significant, that is less than 0.01. Secondary endpoint was PFS, overall response rate, and intervention for CNS metastasis. Next. Next slide. So we can see that in the PFS median was 8.8 with neratinib and capecitabine versus 6.6 with the lab cap. and the overall survival is 24, and versus lab cap it's 22. It's almost similar. Next slide. So the CNS specific outcomes in patient with CNS metastasis at baseline. So lab cap and neratinib, as we can see that the median CNS PFS was 12 months. With the CNS PFS in the lab cap, it was 8.3. Next slide. Then margetuximab, it's a engineered and we can say antibody which alters the Fc receptor and activate the immune response. So margetuximab has the same specificity, affinity to HER2 as trastuzumab, with similar ability to disrupt the signaling. But via Fc engineering with intent to activate immune response, margetuximab has altered the Fc receptor activity. And with trastuzumab so we can see that with increased CD16 affinity, it enhances the innate immunity and more potent ADCC stimulation. And with decreased CD32B affinity, it enhances the adaptive immunity and increase the immune activation.
So I request you to conclude your session in 2 minutes. Thank you.
HER2 specific lymphocyte proliferation increase with the use of this margetuximab. Next slide. So it's a SOPHIA trial in which margetuximab with chemotherapy versus trastuzumab with chemotherapy in previously treated HER2 positive patients. Again, it's an open label phase 3 trial of margetuximab with chemotherapy versus trastuzumab. And next slide. So new drugs for the Phoenix, it's a pyrotinib with capecitabine HER2 positive. So it improves overall survival and CBR. Primary toxicity is diarrhea, increase in the palmoplantar dysesthesias, Hanford syndrome, mucositis. Next, I think that's the last slide. Then is a TULIP. This is a trial of trastuzumab duocarmazine versus physician choice of chemotherapy for patients with previously treated HER2 positive metastatic breast cancer. So in this, patients with locally advanced or metastatic breast cancer, they were randomized to receive trastuzumab duocarmazine versus physician choice of chemotherapy till progression or unacceptable toxicity. And the primary endpoint was PFS by BSER, and the secondary PFS or next slide. So cardiotoxicity, trastuzumab therapy, based therapy that is associated with decrease in the LVF and heart failure. All the causes TDM1, deruxtecan, margetuximab, lapatinib, they all carry warnings for cardiomyopathy, a decrease in the LVEF. But in the clinical trials, the rate for the heart failure or left ventricular ejection fraction declined. It was generally less than 2% with these agents. And ADCs and antibody drug conjugate margetuximab, they have not been studied in patients with left ventricular ejection fraction less than 50% at baseline. And with lapatinib, there is a risk for the QT prolongation. Next slide. So the cardiac safety of HER2 therapy in patients with reduced left ventricular function. So we can see that with, I think I'm short of the time. So next slide. Interstitial lung disease, that is with the taxane, with the anthracycline, with the TDM1, and with the mainly with the new drug trastuzumab deruxtecan. So the specific mechanism is unknown. It's a target independent uptake of the payload in immune cells, bystander effect. So the early diagnosis, we have to monitor the patient for the early signs. Next. So what are the strategies to manage ILD? That is to urge patient to immediately report in case of any respiratory symptoms, any worsening dyspnea, cough, any new pulmonary symptoms, to monitor the patient for early symptoms of interstitial lung disease by X-ray or by imaging, and to confirm it by the HRCT chest, pulmonology reference, bronchoscopy BAL if indicated, and ABG PFTs as per the protocol, and to manage if it's grade 1. Then we have to hold till the symptoms resolve for in case of a deruxtecan. And in case of TDM1, you need to discontinue. If it's grade 2 to 4, then permanently discontinue and treat with the steroid. Next.
Dr. Piyush, I request you to conclude.
Okay. Yeah, that's okay.